Welcome to Advanced Practice, where we brew insights and evidence to elevate mental health practice. In the previous episodes, we explored methylphenidate-based medications, amphetamine-based medications, and non-stimulant treatments for ADHD. Now we move to the question that matters most in clinical practice. How do you choose the right medication for the right patient? It's not by memorizing drug lists, but by applying a structured decision framework. The first step is to define the target. ADHD is not a single symptom. It is a pattern of functional impairment. Some patients struggle primarily with sustained attention. Others with impulsivity, emotional dysregulation, early morning dysfunction, or evening rebound symptoms. If you do not clearly define the impairment, treatment becomes trial and error. The second step is deciding between stimulant and non-stimulant treatment. Stimulants are often first line because they have the strongest and fastest effect. But that assumption does not apply to every patient. Non-stimulants should be considered when there is significant anxiety, mood instability, cardiovascular concerns, a history of substance misuse, poor stimulant tolerability, or when adjunctive therapy is needed. Once a stimulant is selected, the next decision is choosing between methylphenidate and amphetamine. Methylphenidate primarily blocks dopamine and norepinephrine reuptake and is often perceived as more targeted and sometimes better tolerated. Amphetamines not only block reuptake but also promote neurotransmitter release, which can produce a more robust effect in some patients. If one class is ineffective, switching to the other is often more effective than simply increasing the dose. The next step is aligning the medication with the patient's schedule. The key question is not which medication works, but when symptoms need to be controlled. Some patients need coverage only during school or work hours. Others require early morning symptom control before the day begins. Some need extended coverage into the evening. Short-acting formulations may be appropriate for limited time frames. Extended-release formulations provide all-day coverage. Delayed-release options can target early morning symptoms. Longer-acting medications may be needed for patients with extended daily demands. Medication selection should map onto the patient's timeline, not just their diagnosis. Next, consider formulation. Some patients cannot swallow pills. Others may have adherence challenges. In these cases, alternatives such as liquid formulations, chewable tablets, orally disintegrating tablets, or transdermal patches may improve adherence and overall treatment success. Then, align treatment with comorbidities. In patients with ADHD and anxiety, non-stimulants such as atomoxetine or alpha-2 agonists may be preferred. In patients with emotional dysregulation, guanfacine may be particularly helpful. In those with sleep disturbances or hyperarousal, clonidine may provide benefit. In patients with substance use risk, non-stimulants or prodrug formulations may be safer options. Medication should not compete with comorbid conditions. It should work with them. Finally, titrate strategically. Most stimulant medications produce noticeable effects quickly, but increasing the dose beyond the effective range often adds side effects without improving outcomes. Each medication has a plateau where benefits stabilize. If a response is inadequate, reconsider the class, timing, formulation, or even the diagnosis itself rather than continuing to escalate dosing. Across all ADHD treatments, the goal remains the same: improving attention, executive function, and behavioral regulation by optimizing prefrontal cortical function. What differs is how each medication fits into the patient's life. That's all for today here at Advanced Practice. CE credits or CEUs are available for California nurses. Visit us at www.advancedpractice.io. See you next time. Bye.